welcome back to month 3 of our first project at the Genius PT Project. We are here talking this past 3 months about the Therapeutic Alliance and the skills that we need as physiotherapists, as physical therapists in developing a strong therapeutic alliance. We have Alison Sim back with us this month to just ask her questions and just pick her brain a little bit more about some of the challenges that we face as clinicians in developing a strong therapeutic alliance. So Alison, again, is from the land down under. She is from Melbourne, I think, right, Alison, off the top of my head? Did I get the city right?
Melbourne, yes.
Okay, Melbourne.
Yes.
And Alison is an osteopathic practitioner who is very skilled in treating from a biopsychosocial perspective, particularly looking at has developed some strong skills in both cognitive behavioral therapy, acceptance and compliance therapy, and motivational interviewing. So we've really been trying to access those skills over the last month or two, and I want to just talk a little bit more with Alison about how to maybe further our skills in those areas as clinicians. So welcome back, Alison.
Fantastic. Thanks for having me back, ladies.
It's awesome. It's awesome. So Alison, can you maybe tell us a little bit more about how you became so skilled in this area? So if we're a clinician that really wants to develop some good therapeutic alliance skills, where do we go for some training? What does that look like?
Great question.
I think that is the crux of the question, Carolyn, because when we're thinking about something like therapeutic alliance, who is an expert? How do we define someone who's good? And how do you learn about it? And that's the thing, is it's not as if it's a sexy topic. It's not as if it's easy to seek out those courses. I've even been looking for further education on acceptance and commitment therapy, and really there's nothing out there unless you're doing really advanced stuff. There isn't sort of more of that baseline, beyond a 2-day course, how do you learn this stuff? So for me, it was just something I began to value as I explored cognitive behavioural therapy. So that was where things started for me, and that was taught in the master's program that I did. And as well as the actual skills of CBT, so things like the Socratic open questioning and the curious questioning, things like that, what was presented to me was the science behind that and just how helpful it can be in treating things like headaches and low back pain. And obviously what you're creating there is you're not going to fix someone's back pain by talking them out of it, but what you're doing is you're creating a level of trust between you and the patient that allows them to buy in a bit better and to feel a lot safer in trying the things that you might be suggesting. So I'm by no means an expert, and it's very kind of you to have me on as your expert for this series, but I certainly don't classify myself an expert. I'd just say I'm someone who's very interested in this area, and I've done a lot more further study and reading. And I teach in the area, and really, really enjoy teaching the courses because there aren't many people doing it. And I think there is more to be gained by putting a bit more of a focus on this area.
I think almost that makes you an expert, doesn't it? When there aren't many people doing it and you teach, then all of a sudden you have this expertise. So maybe we should call it, you have an expertise. I don't know that any of us ever really become sort of truly expert in something, because there's always so much more to learn and know.
You can always learn more, can't you?
Yeah, for sure.
Yeah, that's right.
You know, I wonder maybe one of the ways that I've sort of challenged myself and learned skills that are outside of my comfort zone is to really start to attend kind of interdisciplinary conferences where you learn from maybe, folks outside of your discipline. And I wonder, I certainly have done a CBT course and took that from some social workers, for example. And I wondered, have you had experiences like that too, where maybe we challenge some of our skill sets by developing a broader based kind of interest or curiosity?
I think that's really key to it, Carolyn, is that interdisciplinary collaboration. It makes you start to realise, well, what have they got that we don't have? And getting us to a point where we're upskilling, we're all upskilling in similar areas, so that if you have a variety of patients, a variety of practitioners who are working with one particular patient, it probably doesn't matter whether they're seeing the social worker or whether they're seeing the psychologist or whether they're seeing the physio, because everyone is talking the same language and everyone has the same intentions and the same goals. And perhaps, perhaps the psychologist might have a bit more of a bias towards treating trauma or looking at people's trauma history, whereas the physio might be a bit more interested in encouraging people to move. But really, we're all talking the same language,
right?
And we all have the same intentions.
But what happens to the scope of practice question? That's a question I get all the time, and I wonder if you get it as well. Is okay, so but I'm not a psychologist, and so what you're telling me is that psychologists, social workers, physios, when we're working in a multidisciplinary pain program and we're working on function, that we use much of the same language and should have the same framework. But am I not stepping on their toes? Am I not working outside of my scope of practice? Right?
Yeah, absolutely. And scope is one of the biggest things that limits us, or the fear of scope of practice. And really, for Australians, I know our national health body that regulates all our practitioners, they've been really hesitant to define what scope is, because if you start saying, well, you can do this and you can't do that, for one, in a socialised healthcare setting where you've got a certain number of practitioners who are out there actually helping, you don't want to limit what they can and can't do if they are skilled in a particular area. And really that means that it's back to the individual in terms of their decision about what their training is and what they're comfortable with doing in what they will practice. The thing with worrying about scope regarding communication and saying, well, I'm not a psychologist, this is not my thing, is that most of the time our patients present with pain. In fact, 95% of the time patients that we see are presenting with pain, and we are talking to them about how pain is interfering with their lives and how upsetting that is to them, how distressing that is. Right. It's often the distress rather than the pain itself or the suffering that comes with the pain that is more disabling and more debilitating and more interfering than the pain itself. And so for us to consider that person as a whole, to just be honing in on the physical function, we're missing out on how we can actually make the biggest change, which is to reduce people's distress, reduce their fear, and help them to understand their condition a bit better. And that's where the acceptance and commitment bit comes into it as well as the cognitive behavioural approaches. So we'd think about Cbt approaches being a very structured way to apply education, and so perhaps in a myth-busting way, we're looking at people's fears and their worries about what the worst thing can happen, and we can use that sort of more defined stepwise approach that Cbt offers us. But then at the same time, I often find when I'm looking in the multidisciplinary clinic that I'll open the notes and that the psychologist will have been having very similar discussions to what I'll be talking about in terms of, in the presence of pain, can you still do stuff that has meaning to you? So now they might be talking about that from a whole life or a bigger picture perspective. I'm talking to them about it in terms of, if playing golf is important to you and the step up from, is that me? Oh, goodness me, sorry. We might have to
It happens, not to worry. For everybody who's watching this, it's in the morning for Allison. It's nighttime for us. So her phone is going to ring. Ours hopefully will not be ringing tonight.
I had checked. I've got my student here who can nod and check and say, I've checked. Of course it was not. But using the more acceptance and commitment approach is thinking about that we don't have to take pain away. We don't have to take the unpleasant bits away to still live a life that has meaning or do stuff that is important to us. And so that is very much about what we're doing with pain, is we're saying we know that this pain doesn't equal tissue damage and therefore we don't need to be as frightened of it. And therefore, can we have a go at doing some things that look like what you would like to be getting back to, because that has meaning. as opposed to just doing, exercises for the sake of doing exercises. Can we pitch our rehab in a way that looks like what the patient would like to be doing, that fits with their values, that is, the bits that pain has taken away? So that's where having an understanding of the different types of approaches, and same as the motivational interviewing, that sort of that different component. They're skills, they're ways, they're a framework of communicating. And the thing about scope is we're largely doing this anyway. We're educating our patients.
We are. Mm-hmm.
But this encourages us to, rather than just perhaps be didactic about our teaching and black and white and teaching things in the same way, this teaches us to take that person very much into the picture, and so that we're tailoring our approach to them. So we still give education, but perhaps if they're quite hesitant or resistant about embracing a bigger picture approach, if they're still really stuck on the idea that they need a cure, we might not ram down pain education down their throat on the first consult. We might wait until we've got a bit more of a rapport. So I think a lot of these, and you can call them techniques. That's really what they are. They're communication techniques. They are about doing what we do better. So it's stuff that we're doing already. Let's treat it like an intervention. Let's treat it like a treatment, because we know that is what the studies say about it, that the better your therapeutic alliance, the better your outcomes are going to be. Let's actually put that science on a pedestal and use it to guide our treatments.
Yeah. So it's very interesting that you started talking about distress, right? And if we look at distress, and if that's our target, is to decrease distress, I think one of the struggles that we have, again, working in scope and thinking about how do I introduce this to my patient, is first of all, we have to measure distress. Right? And so first of all, we have to put some measurements in place, some questionnaires that look at things like catastrophization and fear and depression, anxiety, stress. And if we make assumptions around that piece and just maybe go on some cueing from the patient's words, but aren't necessarily that objective about that piece, I think it's harder to build that trust in, okay, I'm going to tell you my story and I'm going to kind of give you the bigger picture, because we haven't necessarily demonstrated to our patient that we're looking at them from a whole person perspective. Do you have any thoughts about that? Because I actually ran into a problem with that this week with my patients. And I had one patient who came in for prolapse and very clearly wanted to strengthen her pelvic floor. And she did have some low back pain as well. And I standardly look at things like depression, anxiety, stress, fear, low positive effect, catastrophization. And once we actually went through all of those pieces, she was actually able to see the big story around how she really is presenting with a lot of guarding and protection in her low back pelvic region, and how it may not just be about a weakness problem. She kind of built that story for herself, right? Whereas I had this fellow who actually is post-prostatectomy, and I'm really struggling with him at this moment, because because his biggest complaint was to avoid starting to do intermittent self-catheterization. That's why he was sent to me. He also had 2 disc herniation surgeries in his back. He'd had 1 fusion in his neck. He had a very biomedical sort of approach. He just thought it was a structural issue within his urethra that we needed to fix, and that was the problem in his pelvic floor. And he's on opioids. He's got chronic pain. He's not sleeping. But all of that was actually missed on intake by our receptionist. And so he didn't actually get the pain questionnaires. He didn't fill them out for me. And now building this story into this whole person perspective is more challenging, because I don't have all of this other data to kind of really pull that into his story from the beginning, right? And he doesn't want to go beyond the biomedical route, right?
I see. You're getting a sense. And do you think, though, Carolyn, that's because he was sent in by someone up the medical hierarchy to see you for something biomedical?
Well, they both were. So my prolapse woman was as well, and he was as well, for sure. They both were sent in by a urologist for this specific piece, right? And I've been talking to him from the beginning from that perspective, but Go ahead.
Yeah. So with the gentleman, that's quite hard, because his expectations of coming to see you are about a catheter and about post-surgery rehabilitation, and it sounds very biomedical. And I think to switch from that is going to be a really hard task, even in the presence of low back pain and things like that, especially if that's not what he was seeking. So I don't know that you should beat yourself up. I know we were talking about this just before off air, that you were saying that this one who's quite puzzled you and you feel like you're losing him. But I think you have to remember that his expectations perhaps weren't what yours were. And even though you feel like you could help him and you would like to be able to help him with that, maybe he's just not there yet. Maybe he's suffering with his low back pain is not enough to make him seek that kind of treatment. It's not interfering with his life enough. It doesn't bother him enough to actually pursue it more.
Yeah, I would agree. And I think that's where I've come to as well, and have asked him that question. What are your expectations? What do you need from me?
Yeah.
This is what I'm able to offer you, but if that's not what you're looking for at this point, I can give you this piece, right? And so, but it's interesting. I guess where I'm wondering out loud is, if I had had those distress questionnaires from the beginning, I think I would have been able to more objectively build the story for him, rather than try and kind of bring it around. I don't know. Yeah, that's.
I also wonder though, if it might. I mean, I've certainly had plenty of patients who come in with that very biomedical idea, and they actually get quite cross with the questionnaires. Because they're saying, I'm not here to talk about my mood, I'm not here to talk about my thoughts, I'm here to talk about my back pain. And that's what my doctor put me in for. So, I mean, maybe it might have helped, but equally it might not, Carolyn. I think you really got to respect that medical hierarchy, because it certainly exists. It certainly exists for patients. And if they have been sent by someone higher up on the rung than you, they probably are seeing you a bit like a technician, and you don't have ownership of that patient quite so much. That's more like a secondary healthcare setting, isn't it?
Right.
Where you're not primarily treating the patient. And there are certainly times, this probably is a good way to introduce that patient that we were talking about off air with the fecal incontinence. So where you might be offering them something that they haven't presented with, that they actually are seeking help for and that they're interested in. But I guess you gauge that. So before we were talking about a patient of mine who had come in for low back pain and pelvic pain, and into the conversations down the track, once we had a rapport, so 2 or 3 sessions in, she mentioned that she was fecally incontinent and that it was really restricting her lifestyle, but hadn't brought that up with her GP, hadn't mentioned it to her friends or to her daughter, and she was only 62 or 63, so far too young to be debilitated by that. And it was, I gauged enough interest from her after asking more questions about it to say, is this really bothering you? And it was bothering her way more than her back pain was. So perhaps her motivation to do something about it was higher, because it was having a big impact. It was very distressing. It was a massive functional impairment. But perhaps for your guy, his pain is secondary to the distress of the prostatectomy and everything that's gone on there. Who knows?
Yeah, I know. It's always interesting, right? To just reflect back and say,
what could I have done better? Yeah, but you know what's beautiful? You know what's beautiful about that, and that's, that's one of the things I've always loved about working with you, Carolyn, is, and with a lot of our connections across the world, is the reflective nature of our practice. Is that there are a lot of practitioners who don't sit back and go, what could I have done better? Why didn't that work out as well as I could have? The assumption is that they're always right, and they're always, always.
And there's one answer, right? There's not just
one answer.
approach,
yeah, that's right. It doesn't work like that. Humans don't work like that.
Yeah, the answer for me is always it depends. It depends on who it is and what's happening in front of you. I love this line of questioning, because doing a poll of some audiences as leading up to this discussion tonight, listening to people talk and having people ask me questions about very many different things when I go across the country and teach. And most of the frustration people have is, I've been to the courses, I've heard the talk, I do the stuff, but I don't know what to do when I sit in front of my patient on Monday morning. And it's really a paradigm shift to decide, do we do it with questionnaires? Do we not do it with questionnaires? What's the best way? But how do we reframe the conversation so that we're not having the argument? Because I think a lot of people tell me, well, patients come in and they expect certain things. I love to talk about expectations. They expect manual therapy. They expect hands-on. They expect certain things. They expect me to tell them what to do. And it's like, well, but have you ever reframed and asked them what they want?
I think that's exactly right.
Yeah, and
that idea that you were saying,
speak to those people who are trying to take those steps out there, but they're just like, and again, part of it is reflective practice. Wow, that didn't go well. or that went pretty good today. I like that. I mean, I do that all the time. Still to this day, I walk down to the room going, okay, Susan, you just sat there and told this person what to do. You got to go back in and like re-go on this one. That was just a cop out on your part. But I learned from it. I learned what was like, okay, what happened? Why did I go that way? So I'd love to hear your thoughts on that a bit.
Yeah. Well, it is really tricky, Susan, and that is certainly what I found when I started learning about pain science. Was I'd be reading stuff, I'd be doing either my master's or before that a bit of reading, and people often say the same thing after they've done something like the Explain Pain courses is, they get their minds blown by all this incredible information, and then they're kind of left, but what do I do with it? Whereas if you come away from a weekend course where you've done acupuncture or manipulation or whatever, you can usually at least go and play with a few of those. I'm very, very cognizant of that idea when I'm teaching, and I put into my courses a whole lot of stuff. We call it Wednesday syndrome. So you do a weekend course. Monday you go back and you're all excited, and if it's acupuncture, you use acupuncture on 90% of your patients. Then maybe something goes wrong. Maybe you get a bit of you get a bit of a bleed, or someone gets really sore. Tuesday you use it on about half of your patients, and Wednesday you use it on none.
Right.
Because you're running late and you just want to get on with it, and you go back to doing what's normal. And so we always talk about avoiding Wednesday syndrome. We put some things that are usually motivationally interview style based projects to get people to engage with the material, to stop Wednesday syndrome from happening. And a lot of that is about having structure and resources. And if we are starting to do things that are different and they challenge the way that we work and they're uncomfortable, and definitely if we're very used to talking to people about what they're doing on their weekends or what the football team is doing, and suddenly we want to be talking to them a bit more about their feelings and how they understand their pain and how does it worry them, it can be quite confronting, and it can be up in your face as a practitioner, and quite threatening, I guess, in a way. And so the temptation is to want to shelve it. So I advocate having a whole lot of resources. So I have a lot of things written out, diagrams, pictures that you can grab, handouts, things like that can facilitate the discussions and give both you and your patient the idea that this is the direction that we're heading in. Because otherwise, I think if you're left there with nothing, then you're often umming and ahhing, and you get yourself nervous. The patient gives you the stink eye, and then you want to move on. You want to get out of there. So I think making sure that you feel comfortable with your material, and giving yourself whatever props you need can help do that. The other thing is to acknowledge that those expectations do exist. And so, like I was saying with the medical hierarchy, there's no point in beating yourself up. If we know this stuff is real and that patients' expectations really dictate how they respond to you and what their outcomes are. So if they come in and they're expecting manual therapy and you are quite black and white about this and you're not giving them any manual therapy, and that, no, we don't do it that way. And I certainly probably swung the pendulum too far when I started out doing that and disengaged quite a few people. But you need to you need to understand, so you need to ask the questions. What are your expectations? What are you hoping to get out of this? You know, what were you thinking was going to happen? And then at the same time, sort of blending that with what we know works. So for someone who is quite hell-bent on getting manual therapy because they think that's going to help them, I'll often make sure that I'm doing the discussions and the talking while they're on the table. So I'll still do the bits. I'll make sure that I reproduce their pain and stick my fingers into the sore bit if that's what's really important to them, because for them, they're coming in and that's their expectation. And I guess I reflect on my idea with that as well. If I'm going to see an osteo or something like that for a sore neck, I want them to be able to put their finger on the sore bits. But probably as well at the same time nowadays, I'd like them to talk to me about, have I had any downtime? Have I been that classic mum who's running around after her kids and never gets any time to herself? And could that be playing into my headache?
Right, yeah.
Right, and I love one of the questions you talked about the last vlog that we did, which was, what do you really think is wrong? You know, just getting them while you're like working on them and they're there and you're meeting their expectations in some ways because you're getting them to move or you're putting them into positions, whether you're really doing anything or not, you're meeting that expectation. And when you do that, it's kind of I love that last time because it was like the ripe opening for, now you can really kind of get a little deeper with them. What do you really think is going on here? What do you really think is wrong? What are you afraid of? What is really worrying you about this? And you pose those questions so beautifully last time. And I just think those are great ways to, you know, kind of, well, okay, here we go, Carolyn, build a therapeutic alliance.
That's right.
Right? I don't know a better word either.
Nope, there it is. We'll say it over and over again.
Going with it, going with it because I love it. It just makes a lot of sense. Or returning the locus of control to them. What's important to them? What's important to them? I'm really interested in what you're afraid of. Rather than, oh, you know, it's kind of, it was really funny watching something saying, you know, don't cry, don't do this. And it's like, oh, no, actually, let them cry. Let them do this, that empathy thing. What is really worrying you?
Yeah, absolutely.
You know, being right there with them.
What worries you about this? I noticed. Yeah, I noticed that's made you really upset. Tell me what went through your mind. I was going to say another little cheeky hack that can work with the communication stuff, and it is about patient-centered care, is to use a lot of the language and the things that you've heard in the way you speak back to the patient. So if golf or fishing or tennis or whatever has been a goal, or getting back to work, then making sure that you're using that consistently in your talk about rehab and in your talk about goals, and using the elements of their story to show that you've listened. So you'd be talking about, you know, that this has been going on for the last 12 weeks or whatever, and using the details that they've told you back at them to show that you've actually listened. Can be a way of demonstrating that you care and that you're not just treating them like the next person who's walking in the door.
That's great. Brittany, I wonder if you can comment for a moment on, sort of from a new grad perspective, how you either have found, you know, sort of motivational interviewing to be a helpful skill, or where the challenges lie in kind of applying those skills, because you were exposed a little bit to it in university, so that's great in your master's program.
Yeah, I can speak to that a little bit. And I think it depends, again, like Susan had said earlier, on your clientele. So when I'm talking to someone who's a little bit younger, maybe around my age, I feel much more confident in that. But when I'm talking to perhaps someone of a little bit older than myself, who is coming in with that hands-on, you know, I expect to be touched, I expect to be fixed, fix me kind of attitude, then I think I tend to lose confidence in that, and sort of talking about sticking to those values, like Alison was saying, and using those little skills to start. Because I think as a new grad, you tend to think, you know, it's very black or white. So, you know, I'm either using MI all the time or CBT, or I'm doing the manual approach, and it's hard to kind of blend those skills. So I think using that, you know, is a really good way to kind of work on that. But certainly I think that, in our master's program, we did have some exposure, which was excellent. So I think it's probably easier having that exposure in school than maybe perhaps a clinician who's been out for 20 years really used that operative approach and is now trying to switch 180. But it's hard because some, like Susan was saying, some clients you just feel like you nailed it. You really got to the root of the problem, and other ones you're just kind of figuring out what is the balance between what they want kind of from an operative approach and how to blend in pain science and MI, ACT, all that stuff. So it's I think learning the confidence in yourself.
And look, that's part of being a new grad anyway, isn't it? You're trying to put it all together.
Yeah.
Brittany, you came along to the course in May. How did you find the Wednesday syndrome techniques? Were you able to sort of put some things in place, and has it changed your practice?
Yeah, absolutely. I do find that the way, especially just the handouts that you had given, both your pain science handouts, but also you have a beautiful handout with different cognitive kind of distortions that people present with. And so I keep that right by my desk. And so it's really easy to just kind of pick away at it and, always refresh what you're looking at. So I thought that it was really helpful. And I think it's really switched my practice in terms of my confidence. So before I was definitely more on that, doing it a little bit here and there, but if someone seemed like they weren't into the, chatting so much, I'd back off. But looking at those skills and learning to blend that really helped. And I use those sheets all the time. So I think it's definitely about keeping like little tips and tricks up on your.
Great. So that idea of that's great. So the resources were something for you that were quite helpful. So being able to grasp something.
For all the PTs or physios out there that are struggling, I absolutely love what you just said, Brittany, because every person who comes out of PT school or goes into their clinic has their clipboard with all of their tests and measures on it, right? And this is beautiful because you're using, this is a way to pull this in like a manual muscle test skill or a range of motion or a special test skill. This is absolutely perfect because that's what this is. It's getting comfortable with the things that we want to do and we want to use and have something at our feet to kind of remind us, okay, these questions, remember to reflect, whatever it may be, those are those little tips and tricks. But I think that's absolutely brilliant because the closer we have things around us,
and isn't that fantastic
we are to use that. Yeah. And as
we've got this new generation who are coming out integrating straight away.
I'm an older physio, so I can tell you right now, the last time I actually used any kind of, cheat sheet was when I started doing the pain stuff, and I had to have everything around me because it was like, this is going to be the hardest thing I've ever done. So the only way for me to do it was I just had to go all in. And it was like, I'm just pulling out the whiteboard, I've got my pens and markers, and I'm just going to tell stories and be funny and different in my authentic self. But I love that, Brittany, because that's absolutely fantastic, is there are tools, there are tips, and there are tricks. And you were just pulled them right there together with you, like, okay, what do I need to be able to look up real quick if I need to? So fantastic. That's a great point.
And I think I was saying we have an email that goes around that occasionally reminds people of a different Socratic question that you might ask. So perhaps this week try asking this question a little bit more.
Nice.
How does that make you feel? Or what did you think about that? Or just keeps us open and keeps us interesting.
Mm-hmm. Is there a resource that you would kind of use, or do you just kind of create Socratic questions as you come along? Where would you kind of? I'm just thinking about it on our Facebook.
Make them up as we go along.
Just try this one. Try that one. Yeah. We have a new listener joining us. Hi, Rosie. How are you?
Good. How are you?
Good.
Thanks for coming on, Rosie. We're glad to have you here.
No problem. I didn't really know what this was about, so I just tuned in.
You're just popping in to kind of see what's going on. So we're just wrapping up our discussion. This will be taped, so you'll be able to watch the whole thing as well. But we're just wrapping up our discussion with Alison Sim from Australia, talking about the Therapeutic Alliance and motivational interviewing. Do you have any questions that you might have for Alison? Is there anything you can think of in your clinical practice that you would just dying to ask someone who has some expertise in that?
In motivational interviewing, or
yeah, or therapeutic alliance, you sort of a patient that you struggle with kind of developing that connection with?
maybe keeping it if you lose it. Like I do have a client who I know we kind of rocked the boat a little bit, and then I kind of sent her a really nice email and she seemed to come back, but like now keeping that alliance together, you know, going forward and not steering off track maybe.
Okay, good question. Alison, what do you think?
It's a good question, Rosie. So tell me, what I missed with a bit of distortion there? Was it that you pushed her a bit or she pushed you a bit?
No, I think she misinterpreted sort of how I was giving my instructions. She had relayed back to me that she felt like I was treating her like she was stupid, which is not what I meant. So I had apologized, that, you know, like if ever you feel like that, just stop me right there. And, you know, like I really just I felt like I wasn't coming across well. Maybe that's why I sounded like that. So we, you know, kiboshed that and we dealt with it and everything was good. And now going forward, I'm a little nervous about kind of how our relationship is going to be and how to maintain that positive relationship and that therapeutic alliance.
What an incredibly brave and noble thing to do, to email her back. I think a lot of people would have, if faced with criticism like that, might have just dismissed her and got on with it and seen all the other patients. But good on you for actually doing that. That was obviously, a tough thing to do. Well done. That it probably sounds like, when without getting too much information from you, that there might have been a bit of a disconnect between your expectations and hers, and perhaps that's where the disconnect came. What I might suggest with that is coming back to working on the therapeutic alliance a little bit and seeing that as your primary intervention to start with, and to go in as simply as asking a lot more open questions of her. So spending a lot more time at the start, and even while you're doing, it sounds like you're doing some exercise prescription type stuff, even while you're doing some exercise, asking lots of open questions. So, and the key with open questioning or Socratic questioning is there isn't a right or wrong answer. The thing that you use to guide you is curiosity. So you're not looking for a particular answer. There isn't a right or wrong question. Equally, there isn't a right or wrong answer. What it is you're asking questions of the patient that they have to think about, that they have to draw on, and it's often showing that you care, that you're not looking for specifics, that you're really actually wanting genuine answers. And if you go in and spend a bit more time doing that at the start of the question, so saying things like, tell me more about that, or you mentioned this, can I ask you a bit more about that? And then reflectively listening, so when they tell you something, pulling bits out of what they've said to you and feeding it back to them to demonstrate that you've listened. And I think if you're worried about the rapport or the relationship going forward, I think that's the best way to pave the foundations, is just go in with a lot more listening time.
Yeah, I think maybe that's kind of what I did wrong, because I had sort of told her what we expect and not listened to what she was telling me she could and could not do. So going forward.
Yeah.
Could you also, I wonder, Rosie, if you were able to tell by her body language, was she sort of
I knew that day.
Right. And so the question then, or something that, again, I think takes absolute bravery, and I would agree with Alison, kudos to you for emailing her back and recognizing that, this needed to be.
That's amazing.
Yeah, that's great.
Great that we were just talking earlier about reflective practice. That is absolutely reflective practice.
Yeah.
There's nothing more brave and wonderful than that, because everyone benefits and grows.
Yeah. But I wonder, when you see that body language, if you can explore that, be curious about that. I noticed that, you're kind of, backing off a little bit when I'm showing you this exercise, or I noticed that maybe you look a little bit uncertain about this exercise. Can we explore that a little bit? So acknowledging it as it happens may help you to kind of not get into that kind of issue again, maybe?
Yeah, I think so. I think honestly what I did is I assumed, because she told me she was stressed, that it was the stress causing that, and not questioning it. It was just like, oh, well, you're stressed because of these things.
Right.
That's why you're being like that. And I addressed that in the email. So
right. Nice.
Hopefully we both learned from that.
Yeah. So I think I love.
That's a great point, Carolyn. Too. It's certainly something I've got more confident with is calling people on body language, and even to the point where the patients are a little bit aggressive or a little bit angry, is to say, I get a sense that you're. Like I had a lady last week who had obviously been to see everyone, and she walked in the door and she said, I don't know why I'm here to see you. And she was quite rude and abrupt.
Yeah.
And so I sort of tried to talk to her, and she wasn't really forthcoming, didn't really want to talk much, just wanted whatever I was supposed to be doing for her. And so I kind of talked it through to, okay, well, maybe we'll start with these exercises. She was really not, it's giving me some really negative body language. And I said, I get a sense that you're really quite sceptical about this. And her husband was in the room and he was cringing. You could really tell he was quite embarrassed by how rude in a way she was being. And almost calling her on it gently like that was enough to change the relationship, was that she realised she was being a bit of a goose and that she was being quite rude. And I wasn't missing the fact that she was being quite rude, but I didn't actually have to be rude back for her to realise. And it actually turned things quite around. It was enough to get her to say, well, yeah, actually I am quite sceptical. And I said, tell me more about that. She said, I've seen so many physios. I've done this, I've done that, and none of it's ever helped before. And she had a real boom and bust mentality. So she was, she'd always go way too hard, do too much, and then crash out, and then would call that a treatment failure. Right. So that was great. I was able to talk her right through that and say, can you see that's a little bit different to what I'm talking about here in terms of this is a graded exposure program. Everything that we're doing is pitched really low, so we're going to build it up really slowly. It's kind of rule-based, so you don't do more on the good days. But that actually worked really well. And in the end, I sort of also then threw it back to her and said, I totally understand why you're feeling sceptical about this. With your history, I think that's fair, that what you've been through. And I'd like you to go away and have a think about whether you think this is going to be helpful for you. So almost saying, you come to me rather than me coming to you. And I will often, patients who are not getting on board, I'll often sort of put it back in their lap and say, if you're not ready, it can't be me chasing you. One of the doctors last week had a great saying, which I thought was fabulous, which is, you can't be working harder than the patient.
Exactly. And you know what? I love what you were just saying about it.
What a really short little thing. If you're working harder than the patient, you're doing it wrong, and you're not going to win. And so it's a great thing. Yeah, you can't want it more than them. So if you find that's happening, then it's a great time to pause and say, what are we doing? What are we doing here?
I love the way you framed that, though, Alison, because what you actually did was give them the opportunity to space hold. And sometimes people just need to pause, and you don't have to make a decision about it. I try to be clear with people, just space hold it for a while. The decision can come whenever you're ready, but does it have to come today?
Yep.
Do you have to make
exactly? You've had this pain
today? Do you have to commit today? Maybe not. But space hold this. And Rosie, you're so brave. I love it. I love it because self-reflection is probably the hardest thing we do as clinicians. But, giving yourself the opportunity to reconnect in a different way is amazing. And what a gift for that patient to have you with them.
Yeah, well done.
Well done. Well, I think it's probably time to wrap up our discussion. Yeah. It's been fantastic. We've gone in a couple of different directions, but I think that's been a really helpful way to just kind of unpack the Therapeutic Alliance a little bit further. I hope that everyone's enjoyed it. Alison, thank you so much again for joining us twice from Australia. We look forward to you coming to Toronto again soon.
Thank you for having me on again.
Yes, we're so excited.
Yeah.
And if anybody wants to learn a little bit more about Alison and the courses that she teaches, I know for sure that in Canada, she has hosted a couple of courses through Embodia, both on motivational interviewing, cognitive behavioral therapy, ACT, but also on headaches, I think, as well. Do you not have a headache course up on Embodia?
Yeah, there's about 3 or 4 other ones up on Embodia that I did while I was over for you guys. So there's one on headaches, there's one on pharmacology, whiplash, I think. So yeah, a couple of shorter, sort of 1-hour-ish courses on integrating pain science into more common clinical things.
Awesome. So what a great way to kind of access Alison's knowledge and skill set and kind of bring that into very practical sort of clinical application. So check those out.
We will have those links up on the website where you can find Alison and her courses. We will have it at the end of this vlog, so you can freeze frame and write it down. You can also email us on the website. There's a place to kind of email us and let us know what's going on. If you have questions for Alison or want more information that you couldn't find, we can certainly help direct you to the right place. That's what we're here for. And I think, Alison, you're going to be, when are you in North America again? In the fall of 2019 for International Pelvic Pain Society?
San Diego Pain.
Oh, the San Diego Pain Conference in January soon. Yeah, or February, right? Soon,
and then,
very soon.
Hopefully Toronto in October.
Right, for the International Pelvic Pain. And she's going to be doing a post-conference 1-day course. So if you've missed her live and you want to see her, I am going to be there on that Sunday. I can't wait, or Saturday, or whenever it is. But I've already put it on my calendar. I'm very excited. Anytime I can hear somebody like Alison speak is a gift to all of us. So thank you very much. Just for everybody who has watched this before, I just really wanted us to introduce Brittany, who is here with us actually live, where you can see her face. I know on the website we have her beautiful picture and her description, and she is the producer of our show. But she is also Carolyn's daughter and a physio. And we're so glad to have you in here for your perspective, you know, as a younger professional in the trade of physio, and working with the same kinds of things that Rosie has talked about, you know, making that therapeutic alliance and trying to get strong with it. And we're all learning every day. So thank you, everybody, for joining us. And next month, Carolyn, it's Corey Blinken's staff, right?
Yes, so Corey's going to join us. Yes, and we're going to talk about our own confirmation biases and how we challenge them.
And getting our patients to understand the edge, which I love some of the stuff that he does. So that's going to be kicked off in January. Watch the website for more information, and we'll see you on social media as well. Thank you, everyone.
Happy holidays.
Fantastic. Thank you.